Consumer Standing Advisory Committee meeting, being co-chaired by the HSCRC and DHMH. This is Jennifer Barnhart. I'm with the Population Health Office at the Department of Health and Mental Hygiene, soon to be the Department of Health on July 1st, if you've not heard. So just to kind of recap where we are with the Consumer Standing Advisory Committee, we've had discussions, Katie and I have had discussions about, where we are with the all-payer model and the negotiations and the integration for the primary care model piece within the all-payer model. And we've also had discussions of Medicaid participation in terms of their dual to ACO integration for the all-payer model. So we obviously want to use this as a platform to continue to update everyone on those negotiations. So Katie and I will be providing a brief update on where we are for the negotiations this morning. And we're also, I wanted to welcome Chris here this morning. We're really happy to have Ross Martin here. He's going to talk about a lot of the tools that Chris is developing in terms of patient engagement. And I know that's something that the group has been really interested in hearing about in terms of electronic health record systems and potential tools for how patients can access their own health information and some of his population health initiatives within Chris. So thanks again, Ross, for joining us this morning. We really appreciate it. Before we get started, I thought we could just go around the room, and particularly for those on the phone, to hear everybody that is here today. So again, Jennifer Barnhart with DHMH.
Katie Wunderlich with HSCRC. Thanks all for coming.
And Mackey University, Maryland School of Nursing.
Suzanne Schlappman, Maryland Citizens Health Initiative.
Tim Burton, Mental Health Association in Maryland.
Lenny Preston, Consumer Health First, and I'm going to do what they told me to do at the MHBE SAC and tear this up because it has our old name. That way you can't reuse it.
Oh, good. Yeah.
Carol Cronin with the Informed Patient Institute.
Takesha Elliott, Healthcare Access Maryland.
Adrienne Kapov, HCRC.
Andy Demram, HSCRC.
Jen Brock, whoa, what's that? Jen Brock Cancellieri with 1199 Service Employee International Union Healthcare Workers.
And Ross Martin with Chris.
And do we have anyone on the phone? As Jen mentioned, I'm just going to give a quick, brief overview and update on our negotiations with CMS. When our group first met in December, we went through the elements of the progression plan and what our proposal is. Hi, do we have somebody on the phone?
Hi, Nicole Stallings at MHA is on. Morning, everyone.
Good morning, Nicole.
And Laura Wilson from the Maryland Rural Health Association.
Good morning, Laura. Thanks for joining us. So as I mentioned, when our group first met in December, I went over the elements of the progression plan, which is the state's roadmap for continuing our all-payer model and extending the model past just hospital-based services to looking at a total cost of care for Maryland services, both hospital and non-hospital services. So the progression plan was our model, our vision to expand our all-payer model. And since the governor submitted that proposal in December, the HSCRC staff, along with DHMH, has been working very hard communicating with CMS and CMMI on what the details of that next contract will be. And so we have put together a state negotiating team. It consists of the secretary, the chairman of our commission, Nelson Sabatini, two other HSCRC commissioners, John Colmers and Joe Antos, our executive director, Donna Kinzer, DHMH Public Health Secretary, Deputy Secretary Dr. Haft, Shannon McMahon, the Medicaid Director, and then other staff members as appropriate. So that's our kind of our lead team. We meet with CMS and CMMI weekly. So we have weekly meetings on kind of various points of the progression plan to try to hammer out details. And we have communicated with CMS, and we've communicated all the way up to our governor the urgency of trying to stick to our timeline and trying to get this process finished, so that stakeholders who will be affected come 2019 have ample time to plan for, be prepared for what is going to come next. We've had very good feedback from CMS and CMMI on what the state has done to date under the all-payer model contract that we have to date. We've had very good feedback. We've had good feedback from some members of the new administration that are in place, the new CMS administrator, Seema Verma. We've had good feedback from her. So we're pleased with the way that things are going. Those meetings that we're having, the weekly meetings, they're kind of going through bits and pieces of the plan. And we hope to have a term sheet finished by the end of May. And a term sheet is kind of the bones or the structure of what the next contract will be. It will have lots of other details and negotiations that will have to be made after that. But we hope to have kind of the basic structure in place so that CMS and CMMI can run it through their levels of review through OMB and through their OIG, all their legal folks, the budget folks on the federal side, and then similarly we can start running it through our stakeholders. The process up until that point, it's hard to share any details until we have that kind of bones and structure in place. But we do hope to have that finished by the end of May, and then of course then we'll be able to share more with stakeholders. In the process, the meetings that I've been discussing, the weekly meetings on the next all-payer model contract, we've also included the discussions for the primary care, the Maryland Comprehensive Primary Care Program, which Jen will share. But we've been including some of those discussions together because they dovetail and they complement each other so well. The all-payer model, of course, the contract won't start until 2019, and the primary care program we're hoping to start earlier than that. But they both do complement each other. We won't be successful on a next phase to control costs and improve quality across all care settings if we don't have a strong primary care and prevention program in place. So we won't be able to be successful if we don't have some of these other programs that the state is working on in place. So we've been kind of thinking about them, getting them cleared through CMS together or in a side-by-side track for that purpose. As I mentioned, we hope to have that term sheet finished by the end of May, so that between May and October or November of this year, it can go through the federal government clearance process. It can go through our stakeholder feedback and approval process, so that we can have something that is a more finished product, a contract ready to be signed by the very end of the year. So between the end of May and the end of the year, we're hoping all of that negotiation, the back and forth, making sure stakeholders are, we've gotten good stakeholder feedback, making sure the federal government has gotten their partner feedback to have a signed contract by the end of this year, so that in 2018 we'll have plenty of time to plan for what that means for the beginning of 2019. I'll turn it over to Jen to fill in a little bit more about the comprehensive primary care model, but again, this does really support and dovetail. It's essential to our next all-payer model contract in terms of reaching out to all care providers.
Thanks, Katie. So we're going through in dovetail the same exact process for the comprehensive primary care model, meeting weekly with CMMI. Our negotiating team for the primary care model is Donna Kinzer and Dr. Howard Haft. the DHMH Secretary, Dennis Schrader, and then Shannon McMahon, the Medicaid Deputy Secretary. So, so we're finalizing our bones as well in terms of the term sheets. There's several components for the term sheets for the primary care model. These include the roles and responsibilities for what will be expected of practices that participate and what's expected for care transformation organizations that participate. What the learning system looks like for those that are participating. How are practices and care transformation organizations being educated and being held accountable to the participation requirements too. Not so much from a disciplinarian standpoint, regulatory standpoint, but really kind of guiding the participants in the model to ensure that they're staying on track to continue their participation. Other sort of term sheets that are included for our negotiations include some of the financial modeling. We also have governance structures, and another piece that we're working on is what the population health accountability could potentially be. And so this is, when Katie says, we're moving, the all-payer model progression really can't continue without a primary care component. This is the non-hospital setting healthcare accountability piece and the inclusion of them in the all-payer model. And what I like to think about when I talk about like population health accountability is that in the first phase of the all-payer model, we negotiated targets for hospital-acquired infection decreases and emergency department decrease utilization. The corollary to that for the progression of the all-payer model and the primary care model is to have population health targets, which are, this is just very, for example, this is going to take some very intense level of work. But for example, a negotiation towards, a diabetes target for prevention, decreased prevalence statewide would be an example of a population health target that we would, seek to include into the negotiations for the all-payer progression. So those are some of the elements that we are actively engaged in right now. And, to Katie's point, as soon as we have approval to move into the clearance process, we'll begin the concurrent stakeholder engagement and then CMS further approval for the final terms of the all-payer and primary care model. I also just wanted to, for the primary care model, we released a survey about a month ago that was a environmental scan of just statewide interest and basically functionalities that would perhaps point entities into a CTO category. So in population health, we really wanted to gauge what kind of entities really show interest in participating in the model, and also what are the existing functionalities of many health systems, community-based organizations, local health departments, across ACOs, across the state that are already doing this level of work. So we had a good response rate, and we're currently working on consolidating a lot of that information. So it was very encouraging to us, the responses that we got. And yeah, so that's where we are right now. And I just wanted to pause and see if anybody had any questions on the process that we're going through right now. Yeah, Lenny.
So CMS has contracts now with Vermont and Pennsylvania with specific pop health measures. Is that what you're looking at?
Exactly.
Okay.
Yeah.
So just kind of like just so you don't think we're being too vague, until the term sheet comes out, a lot of this is very confidential, and it was the same in Vermont, the same in Pennsylvania. But you can take cues and clues from the things that were included in those states. There were substance use disorder goals, and so there are things that will carry through. You can't necessarily comment on the ones that we're specifically trying to look at. There's lots of things, but yeah, there's we'll be looking similarly to what they required in Vermont.
Yeah, absolutely. And we've been in conversations with the health secretaries there and talking through what the process looks like for them. So yeah. Mm-hmm.
Can you say a little more about who you surveyed? That was confusing to me.
Oh yeah. So the survey was broadly sent out to healthcare leaders across the state, and so it was just a request for responses. It wasn't necessarily a survey, and we received received a good amount of responses back to just get an assessment of interest of what types of organizations would be interested in participating, perhaps within the primary care model. But more importantly, I think for the population health team too, is really to get a good sense of what organizations are already doing across the state in terms of care coordination. So not a survey, just more of an environmental scan. Organizations had the opportunity to respond if they like. Some of the elements of the survey questions were first describe, what type of organization you are, what type of care coordination activities you're providing, social service integration, behavioral health integration, are you doing expert, are you using CRISP, what are your EHR capabilities? So this is sort of a scan of readiness. Absolutely, yeah, a scan of readiness for organizations that might have an interest in participating in a primary care model. Yeah, Lenny.
Question
Yeah,
on the stakeholder participation process. So with the term sheets and so forth, what do you see as the role of this group? And will there be an opportunity to provide feedback on those population health measures, or will those be set by the time we actually see them?
So I would say that so I can't directly comment. I really can't. Like to Katie's point, this is a very this is hard for us. I would be remiss not saying that this is difficult. The success of the negotiations really have an element of confidentiality that leadership at the state needs to be very respectful for. In an ideal setting, yeah, we would love to have stakeholder engagement throughout this process, but I can't really comment on exactly what that's going to look like. Mm-hmm.
I would say though that so once the term sheet is done and we have this 6 months of kind of other detailed negotiations through our stakeholders and through the federal stakeholders, I think there will be some opportunity to tweak and to make sure that we're going to be successful, that we're going to be hitting the right measures, that we're reaching the right population. CMS wants us to be successful. We want to be successful. Certainly, in order to be successful, we need to make sure that we are aligning stakeholders and that that we're reaching the right measures. And so, while maybe the big picture might not be able to change, we definitely will be able to, if there is a need to tweak it in a certain way, I think we will be able to use stakeholder feedback for that.
Okay, well, thank you, everyone. So with that, we're going to hand it over to Ross Martin from CRISP.
Could I use the clicker that will advance the slide? Then I need. Oh, okay. Then I need to point at you or something.
Or can he just have the
Well, while she's getting that, and if you could go back to the black slide, that'd be great, and put it in presentation mode would be great. Not there. Right next to the slider, just over to the left in the red. Next to that, right there. Yep, that one. Perfect. Oh, back up. Yeah, there you go. Okay, well, my name's Ross Martin. I've been at CRISP just under 2 years. I am a clinician by background, delivered babies until about 20 years ago, and then started getting into informatics and health information exchange, trying to make data move in healthcare. Was pretty passionate about trying to change the way healthcare works. I'm standing because I wanted to start with something a little odd that is looking at me a little worried already. I'm a singer-songwriter on the side, and I've written a lot of stuff about health IT, oddly enough. People in the industry know me for my music, but today I wanted to do a spoken word piece to you about this topic, and one that I think will resonate with you. It's called Flow. Tick-tock. Check the clock. It's moving faster, relentless in its quest to stop us in our tracks. Tick-tock. Can you hear it? Faster than my beating heart, something with anxiety, checking over my shoulder for the reaper. He's on a bender, hell-bent on the hunt to sniff down and snuff out those I love. Time won't stop or take a break or hesitate to cut us off at the knees, yet here we stand for what we believe can make a difference if we only make it flow. Today we stand for flow, for what we know is essential to the health of this thing we call a healthcare system. We stand for flow, for pushing information out, getting it to go where it needs to go, flowing into the chasm that separates us from the quality we pay for but do not receive, flowing so that the liquid data cascade and echo, creating ripples of insight that concatenate to engulf us in tsunamis of knowledge. And so we implement electronic health records, trying to make sense of these crazy information, And so we implemented electronic health records, organizing into exchanges, taking chances with taxpayer dollars that we could never afford on our own accord, trying to fix on a massive scale the brokenness of this system that we, in our complacency, have grown to see as normal. Millions, nameless, faceless, suffering under the burden of a system uninspired to go the extra mile or saying enough. I have a name, I have a face, I have a voice. Take a stand. Here I stand, just one man among millions with a family lost in this maze. With a father who died from cancer of his phantom prostate that had been removed 20 years before. No PSAs for 20 years. Why test for something long removed? Maybe because there's a chance that it's not all gone. Maybe the answers are all there, hidden in the data, to know the answer to the question of whether it would have made a difference, a life or death difference, this one simple test. Here I stand, just one man among millions, with a family lost in this maze, with a mother who is slowly losing her way, keeping the memories of her youth, but misplacing those formed an hour ago, her children long away from their hometown, trying to connect the dots of her care by remote control. Help, I've fallen and I can't get up does not traverse time zones. And so we rely on old technology of phone and fax, which is not up to the task, as she rides from assisted living to rehab and the hospital and back again, while her medical records struggle to keep up the pace. Here I stand, just one man among millions, with a family lost in this maze, with a son who enjoys good health, but has already faced the surgeon's scalpel at an age too young for his memory to recall exactly why it is he has that scar in his back, or how his kidneys lack the full capacity others take for granted. How will he know, when he comes of age, what this means for him? His medical records passed down from his elders like an oral history told around a campfire after a hunt for mastodons. Here I stand, just one man among millions, with a family lost to this maze. With a wife who bravely faces cancer number 4 in 33 years, who alone carries the burden of carrying her records from place to place, from diagnosis to diagnosis, from year to year, struggling to keep it all straight so that at the very least, her doctors do no harm. Here I stand, one of the lucky ones, a man with coverage, with knowledge, with friends, who stands helpless to make this system work for him. Here I stand, in a room full of my heroes, who possess amazing superpowers to transform this flow from a trickle to a torrent. I don't presume to know what drives you, what compels you to forego another snooze button's worth of sleep, to return to the battle, to do the heavy lifting, to add another line of code, to write another line of policy, to create another decision support rule, to make one more connection, to solve one more problem, to make it flow. But if you need a story to motivate you, mine is here, and free for the taking. Better still, forget my story and tell your own. Shout it from the rooftops, or whisper only to yourself. Keep that vision sharply focused in your mind, so you can return to the battle, and so that we all can be one among the millions who survive. Know who thrive in the flow. Okay. some days that's a little more emotional than others. I don't know why it was hitting me today. I appreciate you letting me take that moment as a framing moment for what we're talking about, because this is kind of weedy stuff. You know, I work on field lengths of standards for moving data around, and it's unintelligible in a lot of ways, and even for people who've been immersed in it a long time. But Chris, I hope you appreciate that in all of the country, you have an asset in Chris that is unlike any place else. And you are sitting in the reason for it, really. The all-payer model has driven the need for health information exchange in Maryland like it has driven it nowhere else in the country. When you have this alignment between the hospitals, between these competitors who will die if they do not know what's happening outside of their system, they pay attention to this, and they've invested heavily in making sure that data does move. Now, I'm here. I got a call about this at 5 o'clock last night, so I didn't know what other than tell them, update about Chris, tell them what's going on with Chris. And okay, there's a lot of things going on at Chris. But now that I know a little bit more about what you're focused on, I want to shift a little bit. We're going to fly through some slides, and then we're going to get down to some critical things that I need your input on and some thoughts about. Health information exchange, just as a concept, is hard to define. It can mean a lot of things, but data, basically, it does mean that flow of information. Single push messages, it can be inside an organization. It's taking data, and if you think about the big concept of semantic interoperability, what that means is the interoperability stuff means it can go from one place to another, and the semantic part means it means the same thing when you start as when it ends. You can interpret it the same way in both ends, and that part is really, really hard in healthcare. Imagine playing the game of telephone or playing that thing where you go around the room and whisper something in the ear and it comes out as complete gibberish on the other end. That happens in healthcare all the time because this is a very complex topic. It's not like swapping euros to dollars. It's much more less straightforward. You know about the global revenue model, so I'll just skip right over that stuff and care redesign. So Chris, we are a regional health information exchange. And it stands for, and I think it's important to understand, we don't use the name very much anymore, we just say Chris, but it stands for the Chesapeake Regional Health Information System for Our Patients. Now, some patient advocates might look at that and go, that sounds a little paternalistic to me, right? Because this was designed initially to help clinicians share data for their patients, not to talk to patients about their data. And as you can hear from my talk, and some other time we can talk a little bit more about what I've worked on in the past, but I've been very focused on things like personal health records and health information exchange to get the information to individuals, to empower individuals. Chris started off with that vision 10 years ago and quickly had to pivot because of the world around them changing and the needs of the all-payer model and just serendipity and all sorts of things, and it's become a very provider-focused exchange, but it's had a lot of success for that. So we need to transition into this, but the journey for that is going to be challenging, and we want to talk about that. So we started off with Maryland. We got a big grant from the state and then from the feds, and we have been continuing to be largely funded by federal and state funding, but we also get member dollars from the hospitals. We don't charge anybody in the ambulatory side for anything yet, even as we add on new tools and services that are extremely valuable to them. It's a rounding error compared to the value of it, and so we've been able to fund it in different ways. But that's always a question for any health information exchange, how you sustain a model that's inherently not driven by selling transactions. It doesn't make sense to do it as a financial transactional model. So we started off in Maryland. We added DC. We started doing exchanges with Delaware and Northern Virginia. We connected to them as well. We also, just this last summer, became the technical infrastructure for West Virginia, the West Virginia Health Information Exchange. So we also add them, and I'll go into a little bit of that right now. The reason that's important to Maryland is even on the just picking the privacy and security component of our budget, the stuff that keeps us from getting hacked and keeps us from having ransomware thrown in our face or just data losses, inadvertent, having the wrong people looking at the wrong data, that stuff is extremely expensive. And the more data that comes in, the more places that we get it from, the more, in some ways, vulnerable we are as a target, right? So we invest heavily in that. If there's any piece in our budget that has shifted a lot in the last year, it's been going more toward privacy and security. And so one of the ways you you mitigate that cost is by regional expansion. We do think that that's an important model for Maryland to really get the most value out of its investment, to not have to pay for the whole thing themselves. And so this is, us adding in West Virginia on a relative scale was extremely cheap compared to what it cost us to stand up what we currently have in Maryland. We have some guiding principles that we really live by. Our CEO, David Horrocks, is all about incrementalism. We don't do these grand vision things that in 10 years it'll be great. We do something that makes a difference and we add to it. That has some real advantages in terms of returning value quickly. It has some disadvantages in the fact that we built this thing not with a big grand architectural vision. And so this next year, we're really trying to pivot a little bit from innovate, and incrementally grow and change and develop to making sure this thing just works, that it's bulletproof, that it's kind of boring, that it just does what it's supposed to do without a lot of baling wire and duct tape, which is kind of how we do it now. It's a lot of effort to keep this thing humming. So we're going to see a little bit of change in that. But we are a not-for-profit organization designated by the state. We do not have a big model of making money. We're trying to just funnel it all back into this. We've got a governance structure that has a whole bunch of people looking at everything that we're doing. We are owned by the hospitals and funded by the state and feds, and they all kind of look at us and tell us, what to do. And we've been real successful, I think, in keeping this kind of humble position of saying we are an enabler for your vision. We are not the driver of the vision. But I'm kind of biased about this. I do think that all these visions that you have about healthcare transforming cannot happen without data flow. It's just not going to work. So it's good that we've got a lot of folks on board. They watch us very closely. We do have governance from, you can see the folks who are leading up our committees. They are tireless in their efforts. They work very hard for us as volunteers because they know how important this is and critical to their mission as well. Just a couple of words about patient privacy, but then I want to really get back into this a little bit more. We're governed by a number of things. At the base, it's our participation agreement that everybody must sign. It's 54 pages long, and it's just scary looking, but it's basically saying that you cannot look at this stuff. You can look at this stuff for very specific reasons, and you fundamentally have to have a care relationship with somebody in order to look at their data. We also are regulated by the state laws and regulations. We have, I think, a great working relationship with DHMH on helping to define the way our regulatory framework is set. And we also have to comply with HIPAA, with 42 CFR Part 2 for mental health and substance abuse stuff, and other things. And just the data use agreements that we have with the state as well for the case mix data that comes from the all-payer model that we use and distribute. So we have a lot of stuff over top of us. Patients who are participating in CHRIS do so through an opt-out model. Now, there are two ways that health information exchanges have tried to do this generally. One is an opt-in, one is an opt-out. Opt-in means in order to get your data flowing in the system, you have to actively get somebody to sign up to participate in the network. That takes a long time, and almost every HIE that has tried to start this way has ultimately failed because it is a Herculean effort. When we talk to patients and caregivers about what they care about, the vast majority of people think that their doctors should have access to the information about them. Not everybody feels that, though. Some people are extreme privacy advocates and want nothing to do with the system, and they we would get an F from certain organizations, privacy organizations, because we are an opt-out state, meaning you're in the system unless when you see a doctor in that notice of privacy practice that the doctor is required to give you, when you show up in the emergency room, when you show up in a doctor's office, they're required to give you their notice of privacy practices, their HIPAA notice. In that, if they're a participant in CHRIS, it has this paragraph that says you can opt out of CHRIS, and here's a form to do it. If you don't want to use the forms, you want to call us up, you can do it that way. If you want to fill out a form on the web, you can do it that way. You have lots of options, but you're in unless you tell us you're out. We have about 0.5% of people in our network who opt out. It's probably, well, I know it's not high enough, because if you ask most people, well, how many of you have been to the doctor in the last year and have seen that form or know? So if you looked for it, if you kind of paid attention to it, so you can tell, if you're just flying through this, if you're in the emergency room with chest pain, the last thing you want to do is look at the opt-out form for CRISP, right? So this is not an ideal thing, but it's the only way to make this really work and make it, because the alternative is the doctor will look up something once, twice, 3 times, and the third time they see nothing, they will never look at it again. And to get them to come back and look in CRISP for information, it's just not going to happen. So you had to have a critical mass of stuff for somebody to go, yes, this is valuable. I'm going to keep using this. It is our reality and the way we work. So I want to talk very briefly about the tools that we offer, and then get into some other things. But fundamentally, we have 3 core services that we offer to providers, although this list keeps growing and growing based on stuff that we add to it. But fundamentally, there are 3 core options. The clinical query portal is the site where, as we collect data, and we'll talk about all the data sources that we have, it can be available. So you look up a patient, you put in their name, their date of birth, any other identifying information. You get a list of the hits that you get. You click on the one that's the patient you're looking for with the right address, and you look at and it has this, I'll show you a screenshot of it. It also includes the PDMP, the Prescription Drug Monitoring Program for Controlled and Dangerous Substances. I mentioned the opt-out. You cannot opt out of the PDMP. It would kind of defeat the purpose of it, because drug seekers would opt out and you wouldn't see it. So it is the one piece that you can't say no to. The Encounter Notification Service is something that CRISP built through a contractor, Audacious Inquiry, and we ultimately sold it back to them because it was something that had some commercial legs, and we thought that they could do stuff with it outside of Maryland, and they have. They've used it elsewhere. But it's such a simple thing, but it's such a critical innovation that has really made a difference in healthcare in Maryland every single day. So when you show up in the emergency room, we get an automatic data feed from that hospital as soon as they click enter for your record for the admission. It's showing up in the door before you're even seen by a doctor. We get a message. It's a short message, and it says who you are, what your chief complaint is, why you got seen, why you're being seen, and the time, and a couple other critical little things. And what's your disposition? Are you going to the emergency room? Are you getting admitted for observation? Are you getting admitted to the hospital? And we get about 30 of those over the course of an admission. Everything from getting transferred, going to the radiology center, and as soon as you get discharged, we get a discharge one too. Most people don't want to see any of those. They just want to see a couple. They want to see that your primary care doctor wants to know when you show up in the emergency room. Kind of nice thing to know about. And that little piece of information has a tremendous benefit, especially if they don't know you're there, and they can call you up while you're in the hospital and say, hey, you're getting discharged tomorrow. Come see me on Friday at 9 o'clock. We'll get you sorted out for whatever happens. That transition of care enabler is critical. In CRISP reporting services, this primarily, and in the past, has fundamentally used the case mix data. Are you guys all familiar with the case mix data? Okay, I thought so, because it's all payer model stuff, all the claims data coming from the hospital. We serve that up in very innovative ways to give meaningful reports to the hospitals, including things like this new one that we developed called the patient total hospitalization report. And what that says is, if I saw you in my hospital, I get to look and see where you've been in the last 18 months, even if it's not in my hospital, and the charges related to that. And it can help identify, people who really need some better care management or care coordination because they're going 7 different places. And believe me, you'd be amazed at how many people are hitting multiple healthcare systems, even the big ones, because things are across the street. Now, in isolated areas, in places where there's only one hospital in the area, less true, but still, it's still useful to know this information. Just some of the numbers. We're connected to 106 hospitals now, all 47 acute care hospitals in Maryland, 8 in DC, 22 in West Virginia, 6 in Delaware through that a relationship with the Health Information Exchange there, 22 in Northern Virginia through another relationship, and 1 in Ohio through the West Virginia one because they are trading partners. We have 271 feeds, everything from laboratories to radiology centers, clinical document feeds, 132 post-acute long-term care facilities connect to us now, mostly sending us encounter data, but increasingly clinical data. We're really pushing on that right now, trying to get to 170 by June 30th. It's one of my goals. Standalone labs, 16. We have 17.2 million unique patients in our master patient index. That's a bad number because a lot of those are kind of orphans of the same person because we don't have enough demographic information. We can't match them, and we conservatively match. If we can't be really sure that you are you in both of these records, we're not going to put them together, so you end up with two different records, right? So that number should probably be more like maybe 10 million, but we're intensely working on making that better, and that's one of the It Just Works missions that we have. 136,000 times a month, somebody looks up a specific patient and finds a patient in our portal. So that's an opportunity to see something that you wouldn't know in your own electronic health record about that patient. And we send out 1.7 million encounter notifications every month. And right now we have over 1,300 individual organizations, from hospitals to long-term care to primary care practices. And this would include, you know, a big multi-specialty practice with 500 docs would be one of those. So we've got a big foothold now. This is not a science experiment anymore. You can just see some of the graphs of the numbers of how things are increasing over time. So I mentioned the portal. I think I've covered most all this stuff. That's kind of what it looks like when you look things up. You can click on any of those and get like a radiology report. You can actually see the report. We also have connections to images now. We're piloting that, and it's been a very popular thing. It's really helpful for like stroke decisions. You're trying to decide if you're going to send somebody to a tertiary provider and get them treated right away. Being able to share that image, that CT scan from the remote place to the tertiary care center, can really make a life and death difference in those moments. And then just for looking at old films, my wife is a great example. You know, had a diagnosis of a recurrence of Hodgkin's lymphoma right after we got engaged 18 years ago, and it turned out if we had the CT scan from some of her originals, it would have been scar tissue. They would have seen it was just scar tissue. Well, we went through about 2 weeks of tests and $10,000 of gallium scans and stuff before figuring that all out. It was a big waste and emotionally exhausting. The patient care overview is another thing that's on there that really compiles a lot of summary information about what's going on with somebody, including care alerts. I'm not going to get into that right now, but it's a real transformational thing that we're working on. The encounter notification service, I mentioned all of this already. It has stuff, like I mentioned, who they are, when it happened, their primary care if we have it, and we're increasingly really pushing to make sure that the encounters, we know who the primary care doctor is, so that wherever you're seen, we can get you connected back and let them know what's going on. The CRISP reporting services I mentioned, I'm not really going to get into that too much. The PDMP, I think you guys probably know this is mandated for prescribers and pharmacists by July 1st. So we have gone from, you know, something like 30,000 users. We expect to hit about 60,000 by July, because everybody who has a controlled and dangerous substance license in Maryland has to register. Even if they're a researcher at Hopkins who gives ketamine to rats, they have to register. So we get complaints about that, actually, but it is the law. So we've embarked about 2 years ago into this integrated care network effort to try to say, let's use this asset to do more, to connect the dots, provide more coordinated care. And I'm not going to get into a lot of this right now, but one of the things we're doing is providing care management software to people who want to take the information, the data flows coming into CRISP, and make use of it and make sure people get Meals on Wheels and transportation where they need it and other social services, and get follow-up on the things that are for the highest risk patients. And so we're really trying to support that. A lot of people want to build their own, and so in that case, we just feed the care management system data, or they want to acquire a commercial product, but we're also providing that at a basic level. We're trying to do more like the data router one is saying, we really want to make sure that a patient can say, I want this doctor to see my stuff, but not this doctor. I'm not seeing that doctor anymore, and be able to control the dials a little bit more. And that's the part I want to get into with you a little bit. The other thing I want to mention is just a few of the core services that we're expanding into, a few of the services that we're building on up beyond the core services. We're doing secure messaging that's direct thing. It's basically an inbox, an email, Gmail that you can actually send patient data in safely and securely between providers. So you can't send it to regular email. You can only send between direct email systems, and we provide that as a service. .halo secure texting, same sort of thing. We know providers are texting patient information in a completely unsecure way. It's really bad, and so we're providing a way for them to do that in a secure environment that only can go provider to provider and can really help grease the communication skids between an ED doc and a primary care doc, for example. The image exchange I mentioned, the basic care management I mentioned. Caliper is just a quality measurement tool for providers who are required to do quality measurement submissions to CMS. The data feeds. So I've got this in the next slide. The research initiative was what I'm going to mention to you. And maybe this is a good point just to go to the website. Can you just bounce there real quick? So if you go to cristhealth.org, you will see, if you go to cristhealth.org, you'll see our site. One of the things you can look at is if you click on connected providers, you can see this long list of who sends us what and what kind of data we get from them. It's hard to read on here, but you can see it's a really long list, and you can see in the categories. So the message here is that the future is here. It's just not evenly distributed. We have lots of data from lots of places, but not everybody sends us everything. So a lot of times the doctor will say, I know this hospital is connected to CRIS, but I can't get the lab data. I can't get the radiology report. Well, they're not sending it to us yet. And all this stuff just takes a lot of time, and we, bird by bird, bang these things out. The other thing I want to point to are the under services. There's the CRIS Research Initiative at the bottom. So this is something new for CRIS, and this is something I'm actually leading. And the reason I want to mention it to you is because it's really changing the way we need to talk to patients and caregivers. If you think about the HIPAA requirements for what providers can do, they can do treatment, payment, and operations. They can share data for treatment, payment, and operations without your explicit consent. They have to do it in order to get paid. They have to submit a claim saying, hey, I saw you, pay me. And they don't have to ask for permission for that. They have to notify you about that. That's what that notice of privacy practices is about. They tell you that they're doing this, but you really don't have a choice, right? So they can do it for treatment. They got to take care of you. So if they need information to take care of you, they need to be able to share that information. For payment, for operations, so they can do quality improvement things with their own data. But there's this huge opportunity to create a learning health system when you think about aggregating the data in an exchange. And over the last couple of years, the state has worked very hard to create a regulatory framework wherein a state-designated health information exchange like CRIS could use data for research under very tightly controlled conditions. And so tightly that I have been working for a year on getting data to flow for research purposes, and I am just about to launch my first approved use for consented patients. And most all the studies, in fact, we only have 2 use cases right now that are allowed. One is you have an institutional review board, IRB approved study that has patients that consent explicitly to use CRIS, to get their data from CRIS, and then they can use our query portal, ENS. It saves them an incredible amount of effort. So a couple of the first studies that have been approved from Johns Hopkins, for example, the ALIVE study and the MESA study, one looking at HIV and AIDS, and the other one looking at atherosclerosis in multi-ethnic groups. These are long-term, like 30-year studies, and they do a ton of manual work to go find your records elsewhere. And now they can just look it up. And then if they need to get more, if there's something not in CRIS, but this is a huge benefit. But we've restricted these uses to very limited use cases, which the other one is using the case mix data that the HSCRC has a long approval process for getting that data. But sometimes we have data like a connector, the master patient index connector, to tell that that's the same patient across provider domains. That we have to add. And so if the HSCRC approves a release and we approve the inclusion of that identifier, they can get the study or the data for that. Those are the only 2 use cases. And the reason we haven't gotten farther than that, if you ask the researchers, they'll say it's great, this is a wonderful resource to have for things like patient identified, patient consented studies. A real opportunity is in population health studies. So when we talk to patients and caregivers about CRIS, we tell them we can use your data, patients or doctors can use your data for treatment, operations, their quality improvement under certain conditions, and that's it. We don't say research. And in order, our research committee which includes the consumer voice, is adamant about us not moving forward, and we're not objecting to this. We think this is the absolute right thing to do, but not to move forward until we have changed the way we talk about how our data can be used. And even ideally to be able to give people the opportunity to opt out of any participation in any research, whether it's de-identified data or identifiable data or not, that they say, no, I do not want my data ever to show up in a research study. Don't use my, some people think they should get paid for that, or that they just think it's an abuse of their privacy and they don't want it, so fine. So we want to be able to turn that off and still say, but you can still get care. You still want CRISP for treatment, okay, so you can turn it off for research. You can have that choice. We have to build that technology capability, which that part's not that hard. It's the mass communication to explain to people what's going on, to have that sufficient, that's going to be hard. We know we need to do this. And we also, of that litany of things that I've talked about, I have not said one word about patient access. And I know that that's something that's of interest to you. It's something critically of interest to me. Our positioning in this so far has been providers are required to make that available to you under the revisions of HIPAA from the HITECH Act from 2009. And I'll just say an editorial thing. I like to think that I had something to do with getting that piece of wording into that language. I'll explain it some other time. But it is really a really important thing to be able to say that patients can get an electronic copy of their record in a structured format as is available. And that is what the HIPAA language says. But the way that's translated is the providers are doing it through their portals right now. So we can make CRISP data available to them and subsequently make it available to you. But boy, wouldn't it be nice if you as a patient could at least even know, where's all your data? And we could tell you, we know, we can tell you every provider that has a chunk of your data. And boy, wouldn't it be even easier instead of going to 48 places that you could just go to one and say, just give it all to me. Give me everything you've got on me. Let me have it in my own personal health record. So the challenge that we have, please, can you turn on your mic for the folks on the call? Okay.
Does the state have the authority to access and use aggregate data? So if, for example, the state wanted to look at unnecessary EDUs.
I forgot to mention the public health purposes. The state, under HIPAA also are public health purposes. So if they have a specific public health requirement, like reporting for sexually transmitted diseases or communicable diseases, there's a requirement to report those, and they can use CRISP to do things like that. They can use CRISP to do other studies that are considered public health studies.
And that can be done now, I would assume.
Yes. But there are a lot of things that look like kind of public health-ish studies that are really research studies that aren't necessarily a government public health mandated thing. And those would be a research study. And those are things that until we talk about the way we use data, that's just not going to happen. So I mentioned the 17.2 million individual patient records problem that we have. Identifying providers is hard, even with all the medical record number, the UMLS number, the DEA number, the CDS number. We have lots of identifiers, state licenses, blah blah blah. It is, people change jobs, they change geographies. It's messy. It's still very messy. We do not have a unique patient identifier for people, right? It was part of HIPAA that got kind of ripped out and said, nope, not until you do. You're not even allowed to fund privacy or studies about it. Congress would not let them do that, and it's still true since 1996. So we have been without a means for having a unique patient identifier. There are ways to identify patients uniquely, but it's hard and it's not perfect, but it's pretty good. And we're looking at, but it's also expensive. It's doing things like, Experian, for if you've ever gotten a loan and they ask you these questions about, what was your car payment in 2012, and did you ever, own a house here, and is this, and you go, how do you know all this? Well, it's the credit card bureaus that can ask you these questions, and that only supposedly you would know. So this is a means for kind of validating somebody's identity. And, for the opt-out, the bar has been lower. We do ask you for identifying information to say that you are you, and then we can turn off your stuff. But for opting in, for actually seeing somebody's data, we have to really know it's you. And that turns out to be a fairly hard thing. And because we don't, because you're not showing up in our offices in Columbia like you are in a doctor's office, we don't have a relationship with you to be able to do that in the same way that somebody who is walking into the doctor's office can do. So these are some of the things that we're really struggling with about how to play a role in this. We do not want to intermediate ourselves between clinicians and patients. That's something that we've been pretty committed to, which is why we've had this perspective of sharing the data with the provider, let the provider share the data with the patient. But we recognize there's some real values here. And this is where I'm going to shut up and say, talk to us about where you think this should go and the pathway we should take to get there. And I can tell you, the challenges technically about what's possible and also how should we be communicating about the research initiative and more broadly just about CRISP, because we really do think it's time to change the conversation about what we're doing with the data. You can go back to the slides, but I think I'm done. Yeah, I did want to say one last thing. If you go on to the next slide. Okay, this is just, if you think about our evolution, going to our portal is not the goal. We do not want people having to remember a login and password for yet another thing. In fact, when we built all this stuff incrementally, every system that we have has a separate username and password. So one of the first things that we've been working on is single sign-on, so that when you're in the doctor's office or in the hospital, you can click on the CRISP button and not have to log in again, but we know who you are, we know who you're looking at, and we'll show you that patient in what we have. And then the second thing is a unified landing page, so that when you do that, you can access everything you have a right to see within CRISP and not have to, bounce around. And right, that's been actually a long time coming for us. But ultimately, we want these to be embedded services. We want to send these via web services and APIs, these technical things that you ask for a specific piece of data and it shows up in your workflow. And you don't even necessarily know that it's CRISP. It's just right in your electronic health record. It's there. That's what we're building right now and really investing in heavily. And then finally, when you throw in the research component of this and you turn it into a learning health system, this is the huge opportunity of exchange. It's being able to do things like the story I told about my father, of being able to do that study that says, well, it's such a rare event that somebody way out from a prostatectomy would get prostate cancer. His oncologist, his urologist, was very surprised when that happened. Gee, I didn't think that would happen. That's never happened before. Well, if you look at 5 million patients, you can probably find it, right? But you can't really look at 5 million patients that easily without stuff like this. So this is the fundamental opportunity, and to feed that knowledge back into the system and say, let's have this virtuous cycle of health flow, of health information flow. And that's really the vision, I think, that makes health information exchange foundational and fundamental to where we're trying to go. Okay, so now those are my big questions for you. What are your perspectives about how we communicate? Who should we partner with? Is it billboards on 95? Is it is it infomercials? This is complicated stuff to explain, right? It's not simple. So appreciate your thoughts. You first, but you duke it out.
Okay. Coming from the perspective that this is built around the idea that patients have some kind of a medical home, whether it's with an ACO or primary care provider, I'm increasingly skeptical that that's been translated down to the patient and patient care-seeking behavior. What my experience has been is that patients increasingly sort of like bounce between specialist to specialist to specialist, and then also with the added what's happening now in terms of the growth of convenience care and urgent care centers. And number one, when I look at sort of like who you're getting data from, I don't see some of the convenience care and urgent care centers in addition to some of the specialty networks. And when you look at like a patient first, they're a closed system between provider, lab, x-ray, and pharmacy there. So they could probably have a lot of data. And then I'm also interested in how this looks to the providers and where I'm coming from. It kind of looks like what happened to your father. If a provider, patient first, Rite Aid, CVS, MinuteClinic, the Walgreens, or the specialist could go to the patient and say, okay, these are the most frequent lab tests that the patient has had or is having, not just get a lab report of the most one, but to say A1C, that this is popping up a lot for this patient, and to hold a cursor over the A1C and see exactly what it is, the most recent, and what it's been in the past, so you can see trending. Or like with your father, PSAs. has or hasn't had, and the trending of that, or even some of the biometrics, what is their weight and BMI trending over time? Because I don't think providers in the specialist or the, or even the primary care or the urgent care, convenience care, have the time to kind of wade through reports, but they may be very interested in the trends, may be very interested to see that the patient has had a rapid strep 2 days ago at some other convenience care, and so maybe may not need it now, that kind of thing. Is that kind of planned for or looked at in CRIF?
Yeah, absolutely, and I kind of debated about whether or not to make that a dot on this, but the font was going to get so small that I don't think you can't even read it now. But if you think about the embedded services, when you talk about an API, which is an application programming interface, it's a little web service. It's a little, you say, I need a piece of data, and I'm allowed to ask for it, and it's literally a web address, but it's a very specific web address with a lot of stuff on it, and it's got a lot of exchange stuff, and it's a secure service. It pings back and it shoots back information. The reason that's such a critical component of this is because we could spend a lot of time trying to envision better ways to visualize the data, better slicker front end things of this. But we know that the innovation that's happening out in the rest of the world is dramatically better. And so the EHR vendors are also doing this. They're getting the religion of I'm going to have the core stuff here, but I'm also going to leverage smart other people, and we're building there's one standards effort called Smart Apps, and it's a platform like an Apple store, like an app store, for being able to take data and apply it to a tool. It could be a decision support tool, it could be a data visualization tool to show trends, all these kinds of things, and just build it into your EHR and call it, shows up, save some space for it, and now this really great trending image shows up for all the data we have. So we're the data provider for that, but not necessarily the builder of the visualization. We will always probably have a portal that people go to, and over time we will continue to push them to make this stuff better, because it is kludgy. It's really painful to look at this stuff sometimes. It takes a while. One of the things I mentioned, the care alerts, we're trying to have human beings write very short summary messages about complex patients and saying, it's like a message in a bottle from one clinician to another. Say, if you only know 3 things about this patient, please know that they are a very brittle diabetic, and you've got to tread lightly on their insulin, or else they're going to go into a coma. Those kinds of things. That is, I think, another element of this, that if we can have more of those bubble to the surface. I've also been in calls. I was in a call this week with Cerner, talking about an EHR vendor, electronic health record vendor, talking about this thing called CDS hooks, clinical decision support hooks, and it's this thing that's built on those smart apps to say, I want to ask for specific data to help clinicians make decisions, like, hey, no PSA for the last 5 years, and I see prostatectomy in the past. Why don't you order one now? That requires that data feed and the rules about it all. So there's a programming language that's being built about all that stuff, and a way to pick up those rules and embed them in your EHR. We think that could be a really good thing for CRIF to do, to be able to say, we're getting all this data about this patient. We've got tons of stuff that you're never going to read through, but I've got these rules that say, if I see these certain things, I'm going to bubble these. Here are the highlights that we've dug, the needles we've dug out of the haystack. And it's still not necessarily visually any prettier, but it's at the top of the list, right? To say, hey, read me first. And we can do that through those kinds of tools. So that's definitely part of the vision. I mean, what CRIF is today looks nothing like it looked 5 years ago, and it's certainly not going to look anything like it does now 5 years from now.
Well, first, I just have to begin my remarks by thanking you for the beginning, it's not really a presentation, to be able to communicate like that, deeply personal things, it's moving, and it's inspirational, and it's great. So I have to say thank you. So you asked for feedback about how you can communicate with other, if you will, sectors of the healthcare delivery landscape. And I would say an example of that, I've been grateful to be able to work with your colleagues. I'm not sure how familiar you are, so just for 30 seconds. I started a project last summer with, I started with Craig, who connected me with Paul and Mike. And so Paul, Mike, and I went on this road show, if you will, of our last cycle of grantees that we awarded about 2 years ago. And just to refresh your recollection, the types of projects we support are to build the capacity of safety net providers. So by definition, the projects that we're supporting are for low-income folks that are coming from vulnerable populations. Some projects are partnerships among the local health department and a hospital to intercept EMS calls and so forth. I could go into a longer conversation. But the feedback that we got on
they got to go on a couple of EMS rides.
Did they share with you?
Oh, yeah.
So I wanted to just, first of all, thank you for Chris going out with us and making those initial connections. The appetite among the safety net providers who have varying degrees of sophistication in using EMRs is strong. Yeah. And if I had a dollar for every time someone say, well, let's just talk to Chris, and Chris do that and so forth. So I just wanted to first of all say thank you for making those connections, and I'll be following up with Mike and Paul to see how the first 6 months of data that Chris was able to provide these projects. I would say if you're looking for feedback for the ongoing evolution of the services that Chris could provide, I would be happy to continue to connect Chris and participate in conversations with our last cycle of grants we awarded about 6 weeks ago. I would say that may provide you the vehicle, if you will, the connection to these types of programs that are dealing with highly vulnerable populations. So I'd be happy to participate with Chris even more.
Okay. Well, Craig is a great direct resource because I run the ambulatory outreach part, which is it's misnamed, but it's essentially anything that's not a hospital. When I have a team of folks who go out and sign people up and get them going, and we prioritize who we go after based on what the hospitals are saying, what the state is saying, and because it is, our name gets invoked a lot for, oh, Chris can do that, and it's great. Just understand that every time we add somebody, we're not making any more money off of them, and we're having to be, and as I mentioned at the beginning, the incremental growth that we've had and the complexity of the types of connections that we're making are without, in the absence of a really well thought out architecture, is starting to, it's not a house of cards exactly, but it's something that is very delicate, and we have to make it more bulletproof. And so we really feel like we need, even though it's an extremely entrepreneurial environment, right? We've got a bunch of people who love building new stuff, and we're begging to say, let's take a breath and make what we've done work more flawlessly, so we're not spending more and more hours fixing what, just keeping it running.
There is one issue that came up in our meetings with these grantees, and a lot of the grants that we award are behavioral health. So, right. I don't want to get into a detailed discussion of HSCRC and all that stuff, but I understand that has some implications for the types of data that would be shared. So I just wanted to mention that is an issue that comes up.
And we are like minutes away from signing this consent to share agreement about doing our first big pilot on enabling consent for behavioral health information in a much broader way. It's complicated. The SAMHSA rules for consent are, I think they're ultimately unworkable in some ways, because it's every point, talking from this doctor to this doctor requires a consent. This doctor requires a consent. Every direction requires a separate consent, and it's difficult. But there are tools that we're trying to put out there to make that consent possible, to make that data flow.
When you're in a position to start pushing that stuff out publicly, as if you have a distribution list or putting out with folks that get
we're trying to just make it work in small places first, and then.
Yeah, well, I've got about 6 or 7 grants right now that can use it.
Yeah.
So if you're looking for folks that,
Do you know Lindsay Ferris? Do you ever work with her, Lindsay? She heads that up. But afterward, I can.
I have 2 questions and then a comment. I guess just the questions first, quickly. I was curious. You said at the very beginning that you were owned by the Maryland hospitals, so I didn't exactly know what you meant by that. So if you can just maybe say what you meant by that. Second, I'm wondering if how any of this activity you've described relates to patient safety, if it does. And then third, this is more comment. You know, you probably have 45 minutes at most here in terms of getting our feedback. So I'm just wondering if there's a way to, if you've thought about creating a more ongoing way to create kind of really meaningful input for some type of advisory group, consumer, patient, family advisory group to CRISP, if you've thought about that. So
let me start with that last one. Because it was something that I noted in our governance that we really didn't have that, and their answer was, this is the group. Oh. You know, you are the all-payer model, you know, consumer input group. So I'm really glad I'm actually talking to you today, serendipitously. But I think you know, one of the questions is going to be, and maybe this is a feedback for us, is to say, you know, we're not really the group, or it's not, you know, we you know, it's not enough. You need to form a consumer, you know, advocacy group that informs what you're doing. On the ownership part, I wasn't here when we built it, so I don't know exactly how this works, and I can certainly refer you to others. But my understanding is the three major health systems, MedStar, University of Maryland, and Hopkins, were the original, and Erickson. So this whole thing started from Erickson Retirement Community, John Erickson, saying, I am tired of sending my patients with their paper records strapped to them on the gurney to the hospital, and then coming back with no information whatsoever, and this has to stop. And he 10 years ago last summer, he had a dinner with big muckety-mucks at those three hospitals, and they said, okay, let's do something about it. And he provided the initial seed money and hired his CTO from his TV station, I don't know what it's called, David Horrocks, to run this little project. And 10 years later, here's where we are. So the governance is complicated, and it's getting more complicated now that we're adding the nodes of DC and West Virginia. They're kind of getting some seats, but we're making it sure that they maintain their own governance for their local regions, but they have some input into the kind of bigger infrastructure here. But we can't turn it into a 50-person board. It would just really break. So the owners, I don't know, you know, exactly how it all works in terms of where's the real fiduciary relationship thing, but I will tell you practically, we get a ton of input from the state, a ton of input from our members, and I'm at every board meeting, and the conversations are deeply thoughtful about how to do this right. I mean, these are people who are committed to giving up their strategic position with their data to make this stuff work better. And I got to tell you, I spent 4 years consulting for ONC before I came here for the Office of National Coordinator, and I would travel to almost, well, not every state, but I worked with almost every state, either over the phone or when they came here for national meetings. But I traveled to a dozen, you know, Nevada and Wyoming, and my colleague got all the Hawaiis and the Floridas, and I got, you know, other places. But there is no place like here. I can promise you that no one has a level of commitment of the providers to make this work. And again, I think, you know, the all-payer model is what drove them to do it. But once you start, you know, data's a drug. You know, they want to make it flow more. And what was your second? Patient safety. So I think there are some public health things related to it. I think we do reporting on certain things. I do know that a lot of the hospital systems are looking at quality improvement program, you know, things, and they've asked CRISP for data. We're trying to figure out how we scale that, because it is something we don't, you know, it takes a lot of labor and things sometimes to do that. But we are trying to accommodate those things. But I think the learning health system part, the research part, is really going to contribute to that deeply. I mean, these are the sorts of things you can do at a grand scale when you have sufficient powered numbers.
If I can just jump in real quick, just to add a little bit of textural on your request for consumer advocacy and a consumer group. Just to kind of put a finer point on something that Ralph mentioned earlier, that CRISP is really the administrator of the data. There are other policy-making bodies like HSCRC in terms of what hospitals need to be sharing or not sharing, the department in terms of public health, legislators. I think this is only one, the CSAC Council is one area where we can provide feedback to Chris. But Chris really does act as the administrator of the data, instead of making policy decisions about data sharing and that kind of stuff. It's something that we kind of struggle with at the HSCRC, because Chris acts for us as an administrator for our care redesign program. They help us with care alerts. They help the HSCRC, and they help hospitals ultimately get the data that they need. But the HSCRC sets policy, financial policy, in terms of what are the expectations of hospitals in terms of getting on to Chris, using data, that kind of stuff. And so just to kind of put just a finer point.
I mean, they are a separate 501c3, right? But you must have
and we want nothing to do with the rules about what, you know, we do not want to be the judge in any sort of way. We want to provide the data. We want to serve it up well. We want to do that efficiently, but we are really committed to not playing that role. And honestly, we took on a new role with the Medicare data and with the case mix data, kind of the scorekeeper, if you will, for some of the rules that the hospitals were being put under for the care redesign program. And we took, and our board took, a long time deliberating about that, because we knew it could shift our role from just, hey, we're just sharing data, to being looked at as the scorekeeper, like the judge. And we're saying, no, we are just the data provider, and we, you know, the quality assurer of the data. But we really do take that seriously about keeping that neutral Switzerland stance.
And that's not to downplay the importance of making sure the consumers know how their data is used and how we can best help hospitals and other providers make sure that they're communicating well with their patients, and that patients have access to their health records. But I think that policy decision and those are a little bit separate than just the administering the
and I don't know I don't see your placard, so. Hillary, hi.
Otherwise, we'll keep feeding the mic to each other for 5 minutes. I had just a quick clarifying question about the opt-in, opt-out, and then a comment. So once someone has opted out, let's say I go to the doctor this week and I decide I don't want my data shared, opt out, and then 2 years from now, I'm in a car accident and my healthcare needs become infinitely more complex, and I suddenly realize, hey, it might be helpful if my providers are able to share my data and there's more people in the mix. How easy is it to get back in?
You can call us up and opt back in at any time.
Right,
that's right.
Straight up opt back in.
And the data, we can't extract data that we've shared. So once it's been out, you know, we can't. When you turn it off, it's not like we can go back and say all the data that you ever had anywhere is gone. But we stop once it comes through. We also don't turn off the feed at the provider level. It hits our door and then gets thrown out. It says, oh, no doubts it out. I'm dropping it. Once you turn, so you'll have a gap in your stuff. But once you turn it on, it'll be on again.
Great, thank you. And then the comment was, you know, to your question about what's the best way to communicate about this. I hear a lot of benefit for providers and for the system, and certainly that trickles down to the patient. But the way we've been having this discussion, I'm thinking, well, what's in it for me as a patient?
Yeah.
Why should I share my data? And that seems to be a critical message point that isn't coming through.
Absolutely a fair statement, because I think because our customers are the providers and the overseers and all that, that we tend to frame a lot of what we do in that language, because we're trying to convince them. You know, this is a mostly voluntary effort, right? There are certain mandates for certain entities, but on the ambulatory side, for example, nobody has to do this yet, and so we have to convince them. In fact, in some instances, we're giving them grant money to connect with us, to connect their electronic health record with us. And we do need to talk a lot more about what's in it for them. We do on our website a little bit. We talk to, about the patient thing. I would love to just do commercials with your voice on it because I think it's great, and that would be fun. Yes, yes, it is. Jealous. Teresa, did you have a Tressa?
Do you collect the MPI for physicians? And I know it's on the patient file, but do you have a different source for that? And then do you do any, do you look at the quality of the data at all in terms of the patient data, or is that more you get it from HSCRC and move it through?
We do, so on the first question, yes, we do collect the NPI. We have not done it as rigorously as, so when I got here, I noticed that our data set, we use Salesforce.com for our customer stuff, and the NPI was not religiously populated, and I thought that was a really bad idea. So we've been going after and trying to get that more. We do use the NPI registry to validate it. So there are tools to be able to do that, to call it and say, hey, do you have this number, and is it right? Does it match? And your second, I'm sorry.
You do that now with the NPI that you have. You do some validation.
Yes. Yes. And on the case mix data, in terms of data quality, so for one thing, just one of those magical things about maybe unintended consequences of the all-payer model. We have, what, 40 years of claims data that, because it's so tied to payments and revenue and everything else, it is really clean data relative to, what it could be for lots of other reporting. Lots of other reporting is just, very shoddy. But this thing has been, there are departments in hospitals that pay attention, making sure that the tapes, as they used to be called, are come through cleanly. We do validate stuff and change it. There's another, Hilltop is the purveyor of the case mix data. They are the ones who do the initial cleanup, but we are the ones who visually present it and combine it to make it into reports that are useful.
I had a couple of things. First of all, a personal story. So last September, I had outpatient surgery, supposed to be 20 minutes. It was 2.5 hours. I came out drugged, got put in my car, was handed 2 envelopes, and they said, one is for you and one is for your doctor. So no transfer of information on what was a catastrophic event, but that, be that as it may. To Hillary's point, I agree completely about a shift of focus. And I think that we and several others in this group were on the Consumer Engagement Task Force that came up with the Strategic Communications Plan. So I think that there is good information in there that can be incorporated into a large strategy, including CRISP as a part of that communication. My question, and I think I've got some of the answer, but our core mission is advancing health equity. So, which I hope is going to be a population health measure seen somehow. So on the 1,350, I think you said, providers, which is actually much more, what kind of information do you have on those individuals and or practices that would help to inform an understanding of how health equity is being addressed? And the same question too as to the patient information, the demographics and other information that would drive our understanding based around health equity. And if I can, if it's okay with you, I'd like to steal your entire performance. I really appreciate it. I think you should put it on YouTube. If you, it is. Oh, good. Okay. So if we just look up Ross Martin.
Yeah. I have I'm the president and founder of the American College of Medical Informatomusicology, ACME, and I was the sole fellow for a long time. And it's through hyper-specialization. If you narrow the field enough, you can be the best of the world at something. So yeah, I've got a YouTube channel. If you type my name backwards in YouTube, Nitram Soar, you'll find my channel.
Oh, that's just
lots
perfect.
Of things on
I think I can remember that. So I love the answers hidden in the data. So that's where I'm coming from with this, looking at the health equity piece of it.
I have a question for you about that on the health equity. So what kind of things would be indicators to you? I will say that we're trying to, like we've been having conversations with the coordinating center Coordinating Center.
Yep.
Because they do all this social service stuff, and we've had conversations with United Way that has a really big database of all the social services that are available, trying to figure out how can we link some of that in. And I'm aware of some startups now that are doing the same sort of thing. There's one Socially Determined, it's called, which I thought was a pretty creative name, looking at how do we serve up determinants of health in order to match people to services and things like that. There's clearly huge opportunities in reducing redundancy of services, making them available, making them spending them appropriately on the right people, and Uberizing, if you will, the connection between that. And we could someday play a role in that. It's another one of those. We've been itching to innovate in those areas, but we're also trying to do incrementally, thoughtfully do it. So we do see that as a future opportunity. If you boil it down, I mean, CRISP is designed to be a many-to-many connector, saying many anything, many hospitals to many doctors' offices, many patients to many. We connect many to many, and where it's better to do that than to do doctor to doctor to doctor to doctor to doctor. Instead, do one hop from doctor to CRISP to doctor, and do that one time 1,000 times. It's way better, right? That's the network effect. That's the whole definition of a network. We are trying to do that for health information, and certainly expanding into beyond what you think of as clinical care and medical care, and into what can really make a difference. Getting somebody a healthy meal, 3 squares a day, can keep them out of the hospital and save you hundreds of thousands of dollars. It's just being able to enable those things and bring the evidence for those things as well is a key opportunity. It's going to grow over time.
So for the Health Benefit Exchange, I think it's MHCC that maintains the RELIC database, race, ethnicity, language, the cultural competency. So it is looking at race, gender, age, and geographic area, all of those factors that areas would factor into this.
And what was the C?
Cultural competency.
Interesting. So you're imagining if we had a connection to that and could match that patient up to a patient record, we could provide some RELIC score. Is that kind of what it is? Okay. It's not individual identifiable.
Yeah. No, I mean, I don't think you could use it per se, but it's an example. And part of the problem with at MHBE is getting individuals when they fill out their applications to fill out that data. So we're actually working on with them to try and figure out better ways to interface, for consumers to interface with the website in order to get more of that information. I can't remember what the number is now on those that fill it out. It's pretty low. So, but without that kind of information, we cannot drive a health equity agenda and begin to address the social disparities in health. So,
I don't know who was next. Go ahead, Jen.
So I have a question about access to the data and training given in workplace settings or provider settings. We represent frontline caregivers all the way from housekeeping, dietary to nurses, depending on where, in hospitals and nursing homes. So I'm just curious to see, I mean, what we hear most from our members is how many, the ratio of patients they have to care for is just so hard. And so if they had access to more information about those patients, it might help improve quality of care. And I'm just curious to see if you're, I mean, I'm assuming that's up to the provider, but do you offer training to the providers on how to use the data?
I would say one of the things I've wanted to implement and haven't gotten a lot of traction on yet, but I think could be in the cards. We just had a director of marketing communications come on recently, and I think she's going to be a potential champion for this, is to develop a learning management system, like any university or school, online school or whatever has, to create these assets. Because we do have people who go out into the field and train people, but we've got thousands of users, and we don't have that big a staff, right? And so we have to do this in online ways, and we do. So we have training videos and things like that that people get. I think they could be a lot better. We have a lot of work to do to really be excellent at onboarding people and getting them the tools they need and making that smoother. In terms of who gets access, so you have to be a licensed clinician to be the initial primary recipients of credentials, but that individual can delegate to a non-licensed provider for their patients. Right? We also, by the way, audit all this stuff. We use a tool called ProTennis, for example, to use artificial intelligence to monitor who you're looking up and making sure that, names, if you're looking up a spouse or a celebrity or other your ex-wife, that kind of thing, we're tracking that sort of stuff, and we will revoke licenses, and you can get in serious trouble for abusing our data, besides losing your access. Does that answer? Okay.
Thank you so much for this opportunity and to talk with you and to hear your story. One of the things you mentioned was your mother being bounced back and forth. And I think you mentioned wanting to have more people involved in this population health research. And I think people will be more open and interested in the research when they have as much or more control over that access than the researchers, because I think a big frustration is you feel like yourself, your caregivers, the people who are helping you heal have a harder time accessing information than some nameless person at a call center somewhere that you're trying to get for immediate help. So I think if you figure out that piece, then I think you'll get a lot more involvement in the population health research.
I think that's a great point. I really do.
Yeah, and we've been working on a project with the faith community, and in working with the hospitals on it, we hear a lot about how there's all these community health workers and all this care managers and care management systems that are being built around the patient, and then they wonder why the patient isn't engaged.
Yeah.
And I think if these systems were more intentionally built where the patient had that direct access, you'd see people using it. I know I'd use it for managing the care for my kids. That gets over my head a lot. And so that's just a thought. And with this project we're doing with the faith community that we're calling the Maryland Faith Health Network, I think we'd love to work with you in getting this information out and really developing some thoughtful messaging about it with the congregations that we're partnering with, to have them be with the patient's consent, have the congregation be notified when they're in the hospital, when they're discharged. It's based on a successful model from Memphis, Tennessee that's had tremendous success in reducing morbidity and mortality, and we're just getting started here in Maryland, about 1 year into a 2-year pilot, and we're learning a lot. And I know a similar project is Journey to Better Health at Howard County General Hospital, and they are using CRISP for their notifications. Since they're totally in-house at the hospital, it was a much easier lift for them to use CRISP. We're still trying to figure out how we do that, because we want to put information in but not see it.
You want to send us you want to send us a patient panel or a church member panel
of people who have registered for the
people who have consented to do this.
And so we've been working with Craig
turn on the ENS notifications, and they can have those right away. It's one of those. So I think that is a huge opportunity in terms of the things you can do with the network once you have good identity management for people and have a way to do it. So I know we got to end, don't we?
Yeah. I just think if the system can recognize the assets that are already there with the patient, with their family, with their community, that's a huge resource that can really help create a dynamic feedback loop, a really comprehensive one. So thank you.
Thank you.
Just one last comment, because another hat that I wear is I'm on the board of Care First, and I would encourage you to do more with Chris. Huh? Well, a word of caution. There's a name of a person that you ought to contact, Harry Fox. If you're not familiar with him, he's the Senior Vice President of IT at Care First. And you want to talk to him about the Anthem data breach and the state-sponsored cyber attack that it was. because while hospital records of 25,000 discharges a year are not attractive to this particular state, 17 million individual patients are. And so you want to talk to Harry Fox about that and about some of the things that made Anthem vulnerable.
Yeah. Yep. It's the other side of the coin, isn't it? It's great opportunity and the not inconsequential risks, and increasingly, who would have really imagined that this? Well, actually, I know lots of science fiction writers and others who have said this is what happens. You know, you get stuff like this happening, and you're going to have warfare really turned on its ear, and it becomes about data and locking things up. And here, you know, we are a node, we are at risk. It is something real. So there are definitely people at CRISP who lose sleep over this. We hired as our Chief Information Security Officer the former worldwide lead at IBM for data security. And she is from Maryland, has a mom in Maryland, needed to stay home for a while, work part-time, and she's working part-time for us right now, doing just that. Beginning of a conversation. Thank you so much. We'll continue and do more. Thank you.
Yeah, Ross, this was tremendous. I have to say that, you know, your introduction was incredibly moving. I mean, I wanted to echo the committee here. You know, I think that we all sort of lose touch with why we engage in the work we do. And, you know, hearing you give your personal note and finding that integration of work-life is incredibly noble, and so thank you for sharing with us. Yeah. So on that note, I thought we could outline some items that I've heard with the group, resonate with the group in terms of charter component and goals. And Ross, I would be remiss to say that during your presentation, I wasn't writing a lot of words down that would help inform our charter for the CSAC committee. So I was going to stand up on the whiteboard. I'll take the microphone with me so those on the phone can hear me. And, you know, please, you know, stop me, correct me as I move through this. So some of the things that I heard, I've been hearing from the group, certainly, I know we had a lot of discussion in terms of like a patient toolkit, a communications toolkit. I think that was discussed somewhat in our first meeting. Tim Burton had brought that up. Can those on the phone still hear me?
Yes.
Okay, great.
Can I ask a procedural question? I don't know what else.
Yeah, of course.
So when the call went out for nominations, it went out with a scope and charge document. And I'm wondering how what we're doing now relates to what was in that.
So, yeah, so I mean, what I was hoping we could do is sort of outline our progress to date. You know, I mean, I think my personal view is that the committee can be a dynamic working group, and don't want to limit us to, you know, some of the original documents that went out, and maybe build upon that. So, Lenny, I was hoping like I could outline some of the progress that I've heard to date about the group's interest, and then just make this like as interactive as possible. So, yeah.
So I guess my only again, just to understand, so among the things on that charge were actually things that have been in the task force report, like the Gold Star rating system, the consumer dashboard for the all-payer model. So are those still on the table as part of the?
Yeah, I mean, absolutely. I mean, I think I was, yeah, I was just trying to help focus us a little bit, kind of bring it back and help us think through what the future agenda needs are as we build out the rest of the year. Yeah. So yeah, very much similar to what the original expectations were for the committee, but building on that to ensure that this is a dynamic process and building upon the committee's goals.
It's been like 6 months, I feel like, since our first meeting, right? Almost? Or what?
Yeah, almost. Was it December or January? I think it was December. Yeah.
So it might just be helpful to revisit that document for a second and then.
Sure. Yeah. I actually don't have it in front of me right now. You have it. Thank you, Lenny.
So can I just make a comment about that? So when we initially put a call for nominations, that was over a year ago, and at that time it was going to be an HSCRC only led effort, and since that time DHMH Population Health has jumped in, and it's a joint effort. So I think that maybe that's a reason for the confusion. I hadn't been sending that initial charter document out as we were moving forward. But I think that, to your point, many of the elements that you're mentioning have been discussed at several of the meetings as things that should be included in the CSAC moving forward.
I'm not familiar with that. Maybe I can kind of interpret what Dennis. Maybe you might spell out. Okay. Yeah. But I think the point here is, if I'm understanding, you don't mind.
No, please, Mark.
I don't mean to.
Yeah, thank you.
But I think maybe if we kind of select the top 2 or 3 priorities as a group, that might guide the activities of this body moving forward. Is that sort of what you're suggesting?
Yeah.
Okay.
In the immediate future.
Are we all on the same?
Yeah, and I mean, I take Andrea's point. Yes, we brought 2, 3 entities together, so to speak, which personally I think is great. And so some of this will clearly be driven by what the final contract is with the progression model and what's approved for the CPC. So in part, I think it's, some of this is maybe thinking about what can we do before those take effect, because once those go into place, that's a lot of work.
Yeah, completely agree. Yeah. Thank you, Ross. So just to outline, in the original document that went out, and I'll just go through this verbatim. We do have 10 minutes left in our meeting today. So maybe what I'll do is just kind of go through this as sort of a level set, and then we can carve out time in our next agenda to talk through some of the dynamic pieces that we're building upon from our original scope. So the HSC charges to the CSAC include support, advise the Commission on educating consumers and consumer groups about how to effectively impact all-payer model implementation. This would include opportunities to serve on and interact with HSCRC CSAC and hospital patient and family advisory councils and other hospital policy boards. Advise the Commission on policies to support consumers' understanding of opportunities for improved care delivery. Advise on policies that support standardizing hospital processes for receiving feedback. Advise on obtaining and reporting consumer feedback in a timely, transparent fashion. Advise on policies that ensure there is meaningful evaluation of and response to complaints at the state agency level. Advise on establishing and providing incentives to support regular, longitudinal, and effective consumer engagement in the development of policies, procedures, and programs. Advise, in collaboration with MHCC, on the development of a performance measurement system for hospitals to serve as a consumer dashboard. Advise HSCRC, in collaboration with MHCC, on the development and promotion of the Consumer Gold Star or similar system for hospitals. And I believe those were the original charges outlined. And I'll just add to Andy's point, the original charge was very specific to the HSCRC, and now, it's expanded beyond that, DHMH population health. So I guess I'll just pause, and are there questions regarding some of the original elements that were outlined? Any modifications that we want to discuss within this specific scope at this point?
that I think that we should continue on with all of those. I don't think we should swap any out. Adding might be fine, and then prioritizing, but as I hear them again, all of those seem very important activities.
They really fall within this larger issue about communications, which came up earlier with consumers and providers and the whole. So, to me, the big picture, it still remains the communications aspect of this, whether it's the MHCC consumer dashboard or the Gold Star system, which was designed as a way to assist the communication of information on certain aspects, like patients' rights, for example. So I think, personally, I think looking at it within that larger communications construct may be helpful.
I concur with what you're saying, Lenny. In a way, we're operationalizing some of what's in those broader goals that were in that you just cited. So you had originally started with a patient toolkit, which is absolutely in line with the goals that are identified for the group.
And do you want additional things?
I think what we'll do is just, we'll do that in the next meeting. Let's just focus on the original charge, just in the interest of time. And we'll make edits to the original charge, recirculate that to the group, and then we can discuss some of the additional components moving forward in our next meeting.
Broad enough to incorporate your goals, DHMH goals, because it's really broad. It's really communicating and how to do the outreach with consumers and some of the other activities that is exactly what you're looking to do as well.
Yeah.
So the other word I would just put on the table is transparency. Mm-hmm. In all of its many forms.
And I mean, I'll just build on, in terms of transparency, we encourage like frank discussions in this room. So, you know, I hearing from Ross earlier and how he opened, I just thought that was so brilliant for this group to hear, because at the very core of this committee, well, you know, we're representing the patient. And, you know, having those kind of frank discussions, whether they're personal or not, I think is like really appropriate for this group, because, you know, we have the opportunity to inform change here in this room. So I just wanted to add on to that sentiment.
So to dovetail in terms of a consumer focus, I would never neglect the important role providers play, because if they don't have the systems in place, there's nothing the consumer can do to access them and advocate for themselves, or people that are advocating for them can find out information in order to be able to say, do this, don't do that.
So some of the things I heard, so the committee is very comfortable with keeping the charter, the charge as it exists now, adding the components, the advising to DHMH population health, in addition to the HSCRC and MHCC for certain elements. Some additional pieces would be in terms of thinking through the operationalization of that charge, doing so in a way that's very transparent, and also, in addition to patient-centric, but having sort of a provider piece for accountability. Is that accurate capture? Okay, great.
You know, and one thing that might help in thinking this through, putting on my previous strategic planner hat, is that the charge as there is really a set of strategic actions to be undertaken, right? So I think that if we could, and I now that I've given you the document, I can't remember what it says under purpose and goals, and don't give it back. I'm so happy you have it. But I think that if the charge could be put in a pithy paragraph that speaks to the transparency and the communications and so forth, and then you begin to break out those individual items, and we can start to put up a time frame on those. So you create an action plan, and knowing that, you know, ACA may happen tomorrow, or, you know, something else could blow up, heaven knows, right? So we're always prepared for the unexpected. But at least there would be a construct there that might help the HSCRC, DHMH, all of us, and everybody we work for have a better handle on what we're all about. If that's helpful.
I'd like to echo what Lenny said, and if I can suggest one of them that I think may really help drive the rest is the consumer feedback and reporting. If there was a way to figure out, you know, what are those existing feedbacks, and maybe have us look at some of the trends, then we know where issue areas might be, and we can bring that up with some supporting data, because right now what we're bringing is based on our own sort of anecdotal experiences and interactions with the consumers that we serve in our various organizations. But to be able to look at, you know, what are the recommendations and complaints going into hospitals and agencies, and, you know, are there issues that seem to be coming up that we need to think about in a focused way? That might be a way to get us started and build out.
Yeah, I think that's super, and that's something I'll take back to our Deputy Secretary as well, Dr. Howard Haft, because within Public Health Services is the Office of Healthcare Quality, and then also there's the Health Occupations Boards, which, I mean, are complaint-driven organizations in terms of their disciplinary action. So,
well, just to add to that, so our collaborative a couple of years ago started to do an environmental scan of the different places that individuals might have to go, be they individual hospitals, the Hospital Association, the AG's office, the MHBE, DHMH, Medicaid. You know, we came up with about, I think we stopped at 20 because we were getting a headache. So I'm happy to share that kind of information.
And so it sounds like you were summarizing, but I do think having some space at the beginning of the next meeting is still really helpful.
Absolutely.
And give us time to think about it. And
Yeah, because every other month is a hard pace, I think, sometimes. So we can use that space in between to you know, reflect. Exactly. Thanks, Mark. Okay. Great. On that note, motion to adjourn. Okay, great. Thank you all so much. Thank you all on the phone.